Hello.
Hello.
Good morning, sir.
Hi. Good morning. Good morning. Hi, Shrikant.
Hello.
Good morning. How are you?
Good morning, sir. Fine,
Thank you.
sir. Thanks. How are you? Yeah.
Thank you to be there. Was fine. How are you? How is COVID?
Not much here, sir, fortunately.
You are really lucky. You know, we lost Pranesh yesterday. You know that?
Really?
Yeah. You know Pranesh?
Yeah, I know him very well.
Pranesh from Coimbatore.
Yeah, I know him very well.
Yeah.
Oh my God.
For 2 weeks, he was battling COVID and we lost him
God.
yesterday.
Okay.
Yeah.
Oh, sorry to hear that.
Very nice man. You remember? Full of love, affection and all.
Yeah, I know.
So, Manasi, are you there?
Yes, sir.
So, Roop is there or not yet?
Yes, Dr. Gursani is there.
Hi, Roop. Good morning,
Hi,
sir.
Subhash.
Hi. So, should we, Manasi, how many people are there?
Sir, around 50.
So, we can start then. They
Yes.
keep on trickling. No? What do you say?
Yes.
So, we'll start with Shrikant and then there'll be Roop. That will be more logical.
Thank you.
So, are we on, Manasi, are we on air?
Yes, sir, we are.
Okay. So, good morning, dear friends. Welcome on this Sunday Office Neurology series. So today, once again, we have Dr. Shrikant with us, who will be talking to us on the OPD issues in dementia. So Shrikant is a neurologist as well as very well trained in psychiatry. There are very few neurologists like that. And today he'll be talking to us on an important issue of dementia and what are the day-to-day issues in dementia, which can be addressed in OPD itself, mainly with the caregivers. So over to you, Shrikant, please.
Thank you, sir. Thank you. Thank you for giving me this opportunity to share my experiences with how to diagnose, investigate, and manage patients with dementia. So I'll be briefly touching upon the OPD issues that we face with dementia. So I've structured this talk into three basic parts. The first and the major part would deal with issues pertinent to the diagnosis, because the major issues is in diagnosing dementia. The second part would deal with the issues relevant to the workup of dementia, which is also very important to find out what subtype of dementia it is, what are the reversible factors that we encounter in dementia, because that is very relevant to a neurologist, because we all know that even though it's a minority of dementia patients that have a treatable etiology, it is still imperative for a neurologist that we look into the reversible etiology of dementia. And the third important issue is in the management of patients with dementia. So we will sequentially deal with each of these issues in the subsequent 20-25 minutes that I've been given. So we must understand that cognition lies on a continuum. So it is not, these are not watertight compartments. These lie on a continuum from no cognitive impairment or the worried well that we see patients presenting to our clinic. And then that goes on to the mild cognitive impairment group, which goes on to the dementia and the major neurocognitive disorder, which has been renamed in the DSM-5 criteria as the major neurocognitive disorder group. So you might find that these are all not watertight compartments, but these are all smooth, overlapping compartments. So that is why we always refer to these as a cognitive continuum, from no cognitive impairment to mild cognitive impairment to the major neurocognitive impairment or the dementia group. So placing the patient who comes to you with a memory complaint along each of these three anchoring points is very important for us to start treatment and management. That is the first point in trying to manage a patient that presents to you with a cognitive complaint. So when somebody presents to you with a complaint of forgetfulness or any other major cognitive complaint, the first thing that we have to do is to distinguish between normal versus abnormal forgetfulness, because that is the base on which you will have to start investigating and this thing. If you find that it is normal forgetfulness, you can just reassure them and send them home and do not even have to do any workup. So how do you basically distinguish between normal from abnormal forgetfulness? Normal forgetfulness is mild, it is inconsistent, it is non-progressive, and daily functioning is unimpaired. These are the anchoring points on which you base your diagnosis of normal forgetfulness. Whereas abnormal forgetfulness is a very significant forgetfulness which is consistent and progressive, and it is of sufficient degree that it starts impairing daily functioning. If you base your diagnosis of abnormal forgetfulness, whether it is mild cognitive impairment or whether it is dementia, on these four anchoring points, then you're not likely to go wrong. So these are the anchoring points on which you base your diagnosis of normal versus abnormal forgetfulness. If you're pretty sure that the patient that presents to you with a cognitive complaint of forgetfulness does not have abnormal forgetfulness, then you do not have to do any further investigation. Just reassure patients, send them home, ask them to come back after 6 months to further evaluate whether the normal forgetfulness has further progressed into abnormal forgetfulness. That reassures and gives confidence to the patient that he does not have abnormal forgetfulness. So, to find out what symptoms are not suggestive of dementia, we need to familiarize ourselves with what are these symptoms in the first place. Patients may sometimes search for words, for example, trying to ask for something and not being able to get those right words, and then not being able to remember the names of familiar family members or close friends. This can be inconsistently happening to elderly people at some times, not being able to locate car keys or even house keys or other things. And then forgetting what you ate for dinner last night when somebody asks for it, but then getting it back after some time, or when somebody gives a hint, okay? Taking a little longer time to complete task. Entering a room, opening the door of a fridge or a cupboard, and then forgetting why you opened the door in the first place at all. These are not symptoms which are not really suggestive of abnormal forgetfulness. So knowing the kind of memory complaint that the patient comes to you with is very important. These symptoms are not suggestive of abnormal forgetfulness or a harmful or a deleterious brain disease in the first place. So knowing what symptoms, what kind of forgetfulness that the patient comes to you with, and then questioning the patient about what are the kind of this thing, forgetfulness that happens to the patient is very important, because the moment the patient tells you that I'm not able to recall the names of familiar family members or friends, I enter into the room and then I forgot why I entered the room in the first place. I've been searching for keys and I've been taking longer than normal to calculate how much I have to pay, how much change I have to get in back. These are not really symptoms of dementia. So the moment the patient comes to you with all these symptoms, you can be sure that these are not symptoms of harmful brain disease like dementia. And then you can do a memory test and you will find that most of these time, the memory test is going to be normal. So, whereas in a harmful disease, deleterious disease like dementia, the patient forgets what he has had for breakfast or dinner. Even with clues, he is not able to remember what are the things that he had for breakfast or dinner. And then he will be searching for his belongings, personal things, and he will not be able to locate it even after a long time. He will forget appointments. He will forget what day of the week or what a month is it. So these are the signs, symptoms that he's got a impending serious disease like dementia. So knowing what kind of forgetfulness that the patient comes to you with is also very important in finding out whether it is normal forgetfulness or abnormal forgetfulness. Also questioning the patient or the caregiver whether it is progressive and whether it is impairing a patient's ability to carry on with his normal day-to-day functioning is also very important, because that can also give you a clue that it is abnormal forgetfulness. And many of the time, it is very important to remember that the patient or the caregiver, they will always complain that the patient is forgetting. Everything that the patient has in the brain will be labeled as forgetfulness. But then you will have to tease out whether it is a symptom of real memory loss, whether it is somebody else. For example, many of the times I've seen in my practice, the patient presents with a language problem. He is not able to tell out the word, but then the patient or the family member will label it as forgetfulness. Doctor, he forgets my name. He forgets children's name. He forgets the name of objects. Whereas actually it will not be a forgetfulness, but it will be a language problem. He will not be able to tell out the names. It might be a symptom of a primary progressive aphasia. So everything will be labeled as a memory loss, and you must be very careful to distinguish whether it is actually a symptom of amnesia, whether it is a symptom of an impending progressive aphasia. So that should also be the same. It just takes 3 to 4 minutes for you to take a focused history covering all major cognitive domains. And in the busy clinic, you can just ask 2-3 questions focusing on memory, language, and visual spatial function, because these easily lend themselves to questioning about from the patient or the primary caregiver. So in very simple terms, the diagnostic process in dementia consists in essence of the 3 things. You have to establish the presence of objective cognitive impairment, determine the presence of accompanying functional or neuropsychiatric impairment, determine the etiology, including the presence of any reversible causes. These are the 3 important steps by which you determine whether the patient has abnormal cognitive impairment or dementia, what is the etiology, and if there are any reversible causes which are contributing to them. How do you determine if there is objective cognitive impairment in a patient who presents to you with memory complaints or cognitive complaints? Adequate cognitive screening at the bedside is sufficient most of the time, but then you will have to do a very sensitive cognitive examination. That is sufficient in most of the cases, but for some cases of mild cognitive impairment, especially in patients with very good educational accomplishment, in some cases, detailed neuropsychological assessment must be needed. Most of the times, we use a locally validated instrument with norms such as the MMSE, the MOCA, or the Addenbrook's cognitive examination. Most of these are validated Indian translations with published norms. Here are some pearls about cognitive testing. when somebody says I've got high blood pressure or diabetes, we always test the blood pressure or the random blood sugar, the fasting blood sugar. Similarly, if anybody comes to you with memory complaints, it is imperative that you will have to test cognition or memory. A very brief validated testing is enough. It will not take more than 5 to 8 minutes for you to do that. So always test cognition in case of memory complaints from the patient. Use a brief locally validated instrument so that you can objectively document the presence or absence of baseline impairment, and you can also follow up on subsequent reviews. And always remember that the MMSE is not the ideal cognitive screening instrument because it is mostly biased towards language functions. It does not adequately sample memory as well as executive cognitive functions. So try to use your own instrument or some other instrument which is much better than the MMSE. Even though the MMSE is the most widely used and it is also validated very well in a lot of Indian languages, the MMSE is just not ideal for testing cognition at the bedside or in the office. So I use my own cognitive screening instrument. It is called the Concise Cognitive Test, which has been validated in Sri Lanka in both Tamil, English, as well as Sinhala. It has published norms in all 3 languages in many educational and age groups. So I call it the generic cognitive screen because there is nothing original in it. I've picked a lot of very useful subscales and made in that I call it the generic cognitive screen. So you can also make a similar one for yourself. So I include naming of body parts, medium frequency body parts, include at least 7 to 8 medium frequency body parts, include at least 4 to 5 unrelated words as a memory test, include both registration of these 4 to 5 words, followed by delayed recall as well as recognition, because delayed recall and recognition is very sensitive to the presence of executive function as well as subcortical disorders. This is what the MMSE lacks. So that is why it is important to include delayed recall as well as recognition. So include at least 4 to 5 words because testing memory with just 3 words is not adequate. Sometimes patients even with moderate dementia can adequately pass the 3 words. Whereas if you want to test patients in the milder stages of dementia, 4 to 5 words are much more sensitive. Include category or letter fluency according to the educational level because that is a very sensitive test of executive function. This also the MMSE lacks. Category fluency for patients with lesser educational accomplishment. Letter fluency, patients with at least who have collegiate level educational attainment. Intersecting pentagon copying and clock drawing can be included as the visuospatial test, which are very, very sensitive. Imitation of meaningless hand gestures, include just 3 or 4 meaningless hand gestures, which are the most sensitive tests for estimation of ideomotor praxis. So if you include these 5 subscales in your cognitive screening test, you would have had tests for amnesia, aphasia, apraxia, agnosia, as well as executive function test. All these 5 cognitive domains would have been included, and including all these 5 tests would not take more than 10 minutes in an ideal cognitive screen. So this is much more sensitive than using a test like the MMSE, which does not sample all cognitive domains equally. And even those domains which are included are not adequate. For example, a 3-word test is just not adequate for milder dementias and just not at all sensitive for mild cognitive impairment. And then you also have to include a brief assessment of functional abilities because it is very, very essential in distinguishing mild cognitive impairment from dementia. In MCI, there is cognitive impairment without functional impairment, whereas in dementia, there is functional impairment accompanying cognitive impairment. And if you include only 4 elements of functioning, that is enough for you to assess functioning, and it can be completed in about 3 minutes. The most sensitive questions about functioning include medication intake, money management, telephone use, and using newspaper or the television, which all of the elderly people do, which is not gender biased and which does not include a lot of motor impairment. So So patients with the motor dementias like vascular dementias and Parkinson dementias also will not be negatively affected by all these questions. So just 4 questions that consume less than 3 minutes can also be assessed in this. So it's very useful. The next most important is the behavioral psychological assessment. Always remember that dementia is not just a cognitive impairment. Dementia is a cognitive behavioral syndrome. So if you just focus on the cognitive syndrome, you'll only be assessing 50% of the symptoms of dementia. Don't leave out the behavioral psychological assessment. You also have to assess about the neuropsychiatric symptoms of dementia. Focus on depression, psychosis, frontal lobe behaviors, REM behavior disorder, agitation, and anxiety. 2-3 questions for each of these domains is just sufficient. It will not take more than 7 to 8 minutes for you to assess all this. In effect, 30 minutes is just enough for you to comprehensively assess dementia in your busy office practice. These are the screening questions for depression that I use in my clinic. Ask about low mood or sadness, loss of pleasure or enjoyment. Do not ask about loss of interest, because loss of interest basically checks for apathy, which is not the same as loss of pleasure or enjoyment, which is anhedonia. Loss of interest can be seen in all neurological patients without the accompanying depression. Okay, so don't ask about loss of interest, ask about loss of pleasure or enjoyment. Ask about ideational symptoms of depression like worthlessness, self-criticism, or hopelessness. Lastly, ask about sleep changes and appetite changes also. Screening for psychosis, just 3 questions. Ask for simple paranoid delusions like delusions of theft, delusions of strangers being present, delusions of one's home not being one's house not being one's home. These are the simple delusions that you get in dementia. Also ask about misidentification delusions, which are unique to dementia, like imposters being present, a particular person not being the same. Okay. Also ask about visual delusions, which are very common in dementia with Lewy bodies. Rarely patients can also get auditory hallucinations. Of course, screen for frontal behaviors, which are the important aspect of the diagnostic criteria for behavioral variant frontotemporal dementias. The 5 most important things are lack of initiative, apathy and social withdrawal, loss of social manners, disinhibition, which is one of the things. The unique thing about behavioral variant frontotemporal dementia is that both apathy as well as disinhibition are present from the beginning in the same patient. Apathy, disinhibition present in the same patient from the beginning almost always point to the presence of frontotemporal dementia. They also manifest lack of empathy and personal warmth towards grandchildren, family members, and pets. They have repetitive stereotype speech as well as actions, and they have altered food preference, especially with fondness for sweets, carbohydrate, and the sameness, fondness for the same kind of food for all meals. The second most important portion of this talk will be on the diagnostic testing that we need to do. Diagnostic testing is always divided into tier 1 testing and tier 2 testing. Tier 1 testing is mandatory testing that every patient with dementia needs to undergo. And that is the minimal testing, which has been recommended even by the American Academy of Neurology. This is a minimal testing, and that is thyroid stimulating hormone, vitamin B12 testing, and brain imaging. This is what I also do for all my patients. This is sufficient for the majority of all patients with suspected dementia. This can identify the majority of patients, okay? And preferably MRI brain imaging is indicated. If the patient is unable to undergo brain imaging with MRI because of various problems like not being able to cooperate for MRI testing or having pacemakers or heart valves, then you can go in for a CT scanning. The MRI protocol should include at least axial T1, T2 flare images to look for both anatomical imaging like atrophy and also for vascular changes, and coronal T1 images, which are the most important to pick up hippocampal atrophy, especially including thin sections of at least 1 to 2 millimeters on the coronal 3D images. And do not forget to ask for diffusion weighted imaging, which is very important in diagnosing Creutzfeldt-Jakob disease, prion diseases. That's the most important MRI thing, the test that you can include in rapidly progressive dementias. If you suspect that patient might have an atypical presentation of dementia, then you have to order for tier 2 testing. That includes CSF analysis, not only for inflammatory dementias like autoimmune dementias, for prion diseases, also for neuroinfections, chronic meningitis, which can present with dementias and other things. And of course, if you suspect normal pressure hydrocephalus, you might have to do a diagnostic or a therapeutic lumbar puncture, letting out 30 to 40 ml of CSF and looking for this thing. Very rarely, if you have any doubts, you will have to do CSF and look for the amyloid, beta amyloid protein, as well as tau levels, measure the tau levels in CSF, cerebrospinal fluids. You frequently also ask for brain PET, PET CT or the PET MRI, and you can do either the FDG PET or the amyloid PET. I have only access to FDG PET in Sri Lanka. I don't have amyloid PET. FDG PET, the metabolic patterns can differentiate between Alzheimer's versus frontotemporal versus Parkinsonian dementias, or even sometimes normal pressure hydrocephalus, where it demonstrates subcortical hypermetabolism. If you have access to amyloid PET, it can show the amyloid deposition in Alzheimer's disease. Of course, in rapidly progressive dementias like CJD versus autoimmune encephalopathies, it can also show, give you valuable information. Other blood work, including full blood count, erythrocytes elevation rate, metabolic things, and autoimmune markers can also be worthwhile as dictated by the clinical picture. What are the reversible causes that you should specifically look out for? In my clinical practice over the last 15 years, working in a private sector hospital where I've seen more than almost 1,000 patients evaluated in the memory clinic, I found out these are the major causes of reversible factors. I've mentioned CNS infections last because I have really not encountered a lot of CNS infections as the causes for reversible dementias. I've also encountered, for some unexplained reasons, very, very few causes of autoimmune encephalitis as well as CJD as causes of rapidly progressive dementias. Not for want of this thing, I also look for this thing, but for some inexplicable reasons, unlike Indian counterparts, I've seen very few rapidly progressive dementias. The top causes that I've seen as reversible factors in dementia patients are depression, use of anticholinergic medications, normal pressure hydrocephalus, and chronic STH. I've very, very rarely seen hypothyroidism and mutable B12 deficiency. Alcohol misuse, sedative hypnotic use, tumors, CNS infections are very, very rare. I've just seen one case of hypercalcemia presenting with dementia. I've seen one case of hepatic encephalopathy presenting with dementia, which was not recognized on blood testing. We picked it up on MRI as manifesting as T1 hyperintensity on the basal ganglia. And subsequently, we did the serum ammonia, which was very high. So the top 4 causes of reversible causes that I've seen in my clinic are depression, anticholinergic drug use, normal pressure hydrocephalus, and chronic SDH. So a limited workup, a blood workup, and an imaging workup is sufficient in most cases to tease out a reversible cause of dementia. The last and the most important part is the treatment aspect of dementia. So what are the treatment pearls that we should always keep in mind? Cholinesterase inhibitors are the mainstay in all dementias. Alzheimer's, vascular dementias, and Parkinsonian dementias, both DLB as well as Parkinson dementia at all stages. And donepezil is the best tolerated, much more better tolerated than ribostigmine and galantamine. Can be used in the mild, moderate, as well as the severe stages of all dementias. And once the patient with a mild stage of dementia progresses to the moderate and severe stages, you can add memantine. But if a patient presents to you in the moderate to severe stages, then you can straight away add memantine and donepezil. If the patient is unable to tolerate cholinesterase inhibitor, memantine can be the only drug that can still be used. There is weak evidence that memantine can be added in vascular dementia, but the strongest evidence for memantine is still only in Alzheimer's disease. There is no evidence for memantine in other dementias like frontotemporals or Parkinsonian dementias. Slow titration of cholinesterase inhibitors and memantine over weeks should be the norm. Take at least 4 to 6 weeks to uptitrate cholinesterase inhibitors and memantine, because side effects can put off the patient from continuing with the medications. Take a baseline EEG before starting cholinesterase inhibitors. Monitor the pulse rate at each visit while on cholinesterase inhibitors, because we have encountered patients with bradycardia and heart blocks while on cholinesterase inhibitors. Keep the caregivers informed of expected initial adverse effects to prevent discontinuation. That's very, very important, because once you keep the patients or the caregivers warned that nausea, vomiting, some GI upset can happen, the caregivers are much better prepared, and you can minimize the rate of discontinuation while on these cholinesterase inhibitors. If you keep the patients and the caregivers forewarned, then the rate of discontinuation while on cholinesterase inhibitors is less than 5%. So that's been the usual trend in my practice. Managing the behavioral and the psychological part of dementia is also the mainstay in the moderate to severe stages of dementia. Many patients come with just insomnia without agitation or psychosis or depression. In those patients, it is very essential to avoid benzodiazepines, because benzodiazepines actually make the cognitive impairment worse. It's better to use the EZ drugs like zolpidem, zopiclone, or zaleplon. You can also use trazodone if sedation is needed, or escitalopram if sedation is not required, especially if there is agitation. These should be the first choice for agitation. If there is coexisting psychosis or severe agitation, and if trazodone and escitalopram are not working, then you can use atypical antipsychotics. Atypical antipsychotics carry a black box warning by the FDA, because there is a higher risk of death from cerebrovascular accidents for elderly patients with dementia who have been prescribed these atypical antipsychotics. So keep them as the last resort. Don't even use small doses of atypical antipsychotics just for insomnia. Use them only as a last resort for patients with severe agitation. But of course, if the patient is psychotic, you will have to use the antipsychotics. But even then, use the smallest doses. Use drugs which have the highest safety profile, like quetiapine or aripiprazole. Quetiapine if sedation is needed, aripiprazole if sedation is not needed. Even then, use only the smallest doses. And for the shortest possible time. Always keep in mind that after about 8 to 12 weeks, you must try to withdraw them if the psychosis and agitation have abated. Don't forget the non-pharmacological approaches. Cognitively stimulating activities should always be encouraged. These include reading, playing games such as chess, bridge, Scrabble, doing Sudoku and crosswords, learning a new language, active physical exercise, including both aerobic exercises like walking, swimming, cycling, etc. Social interactions with others, which is very, very important. Attending family events, social gatherings, religious gatherings, and sticking to a healthy diet, such as a Mediterranean diet that includes a lot of nuts, berries, greens, and fish. These non-pharmacological approaches have also been shown to play a very important role, not only in slowing down the progression of dementia, but also in preventing the progression from MCI to dementia stage. So it is not only the pharmacological approaches which are very important, but non-pharmacological approaches should also be encouraged. Putting the patient in a daycare program with the nearby dementia, this thing like the local Alzheimer's Disease Association is also very important. So both pharmacological and non-pharmacological approaches should also go hand in hand. So this is what we say, all hands to the pump approach, both pharmacological as well as non-pharmacological approach. So all this management, including advice to the caregiver, can all be completed in about 30 minutes time. So dementia should not be diagnosing and treating dementia and giving advice to the caregiver. It need not be a mind-boggling approach. So if you, all this can be done in 30 minutes is what I do in my busy clinical practice in the office. So I think if you approach a systematic way, I think it can be a fulfilling exercise for both the clinician as well as the patient as well as the caregiver. I think that should be the take-home message for all of you from this talk. Thank you.
Thank you. Thank you, Srikanth. I think you really made it very, very comprehensible and very easy to understand. And, it can be called Dementia for Dummies. There's a series of books, and that was really, one of the most difficult things is to make a difficult topic easy. And you did it. And I remember how I accidentally met you in that Madras conference, and we were looking desperately for some neurologists who had been trained in psychiatry. And I don't know how I found you. They said that if you intensely want something, the nature conspires to give it to you. And you just hit across me. And I said, oh, you are the person. So we really enjoyed your talks. I think some of the points which you made are very pertinent. That, many of us think that the moment a person says memory test, we send him to neuropsychologists, and neuropsychologist does a long interview. And in the end of it, even if the patient is not demented, we label him as demented. So you very nicely said that a routine interview in an OPD, most of the patients you can screen out just by routine questions about his day-to-day life. And you also highlighted the point that we should also ask them questions about behavior, not only memory, and also see whether they are depressed. And initial investigations, which you said is just B12, thyroid, and MRI are enough. And only if we get some clue on that, then we can go for further investigations, which are very valuable points, particularly for the younger neurologists who are sitting. But Srikanth, you have worked in India also, and you have been working in Sri Lanka also. Yes, it is very interesting that you are saying that in Sri Lanka, B12 deficiency, CJD, autoimmune encephalitis are not common. It's very interesting. I was thinking that the Sri Lanka epidemiology will be same as in India, but it's interesting to know that that there is a difference, because in India we see, you must have seen CJD, autoimmune encephalitis, very common. So I think that's an interesting phenomena. So thank you once again. I think in future we will have many more sessions, probably fully divided. We'll have theme-based in cognitive neurology, in neuropsychiatry, and other chronic diseases. We'll be troubling you again, Srikanth.
Thank you, sir.
Your lectures were very well received. Thanks a lot. Today we are not having questions and answers. So thank you very much once again. Thanks a lot.
Thank you, sir. Thanks.
Now you can unshare your screen.
Sure.
So dear friends, now our next speaker is Roop Gursani. And Roop, are you there?
Yes.
And about Roop, I can definitely say that you need no introduction.
Thank you so much.
You are the producer and director of this movie, So, everybody knows Roop actually began as an epileptologist, but I think he is an epileptologist, but down the way, he also fell in love with palliation and chronic disease care, and more of his passion is there. But today he's talking on the care of the chronically ill patients. Now, chronically ill patients it doesn't mean one disease. It means stroke, it means multi-infarct, it means Parkinson's, it means motor neuron disease. It's very difficult, the way the patients come to us with expectations. All of you know that, how to address their expectations, how to counsel and all. So we have a special lecture on that by Roop Gursani. So Roop, you can give your lecture because we don't have much time. We will not have questions and answers. It's already 10:40 and our next session is supposed to start at 11. So you can, in next 20 to 25 minutes, you can just give your thoughts on this important issue of chronic disease management in neuro patients. Roop Gursani, please.
Thank you, Subhash. This was not really a topic that I would have chosen if Subhash hadn't pushed me into it. But as always, you learn when you teach. So this is my presentation on chronic disease management. And really, we have to look at what model of neurologic practice this is focused at. For us, it's generally community practice, which means OPD, indoors, emergency, everything, practicing solo. But of course, there are not too many people doing group practice. Academic departments may find parts of it useful. We don't have neurohospitalists, though we do have some neurointensivists. We have some people who do OPD practice alone, and there are people who do subspecialty practice. So I suppose all of them can pick up bits and parts from this. But essentially, when I was making this talk, I made it for the fine audience, and specifically for my colleagues from the Maharashtra Association of Neurology, because we have an amazingly fine group where we share a lot of stuff, and frankly, we learn more than we teach there. So the aim for this talk is to develop a conceptual model for our situation. I said earlier, most of us practice solo. On top of it is a pay-as-you-go system. You watch Dr. Srinivasan, his is a comprehensive universal healthcare. That's not the way it is with us. Our patients have to pay every time they come and see us. And then came the question of which diseases should this cover? Everything, including migraine? No, I thought all the patients whom you will grow old with. And now there are more and more of them. But if at all, my inclusion criteria, if you could call it, all conditions where the patient is likely to be under your care for more than 1 year, the patient has been admitted or may require admission and has potential mortality in the next 5 to 10 years. These are the cases where this talk will venture. And what you will take on will depend on your personal interests. I would strongly urge you, if you have a subspecialty interest, please refer patients outside your interest away. But if you plan to manage everything, please learn neuropalliative care, especially if you plan to manage anyone with a potential survival of under 2 to 3 years. And how can you do that? Well, I am setting up for the International Neuropalliative Care Society, 1-year course, a certificate course on neuropalliative care, which will start in January 2021. It will be 90% remote learning. There's only a small component which is going to be physical learning. Okay, what are the possible conditions that we deal with? For me, it's refractory epilepsy, especially when there is disability, whether it's due to seizures or even otherwise. Parkinsonism, motor neuron disease, dementia, including vascular. But it's also severe neurologic injury with permanent disability. And here you have to distinguish between the old versus the young, the level of care required. So one extreme is a cognitively intact quadriplegic. Like I think Hrithik Roshan in that movie, versus say another young individual who's got traumatic brain injury, is a little demented and has preserved mobility and has behavior issues. So let me point you back to the 3 essential functions of a physician: diagnosis, therapeutics, and prognosis. And this journey will encompass all of them. Remember that preclinical diagnosis is coming up more and more. Say, for instance, you must have read about the preclinical blood diagnosis of Alzheimer disease, which actually came out splashed in all the newspapers, versus after symptom onset, then therapeutics and prognosis. So let's start by beginning by knowing your patient. And this is a paper that is well worth reading. It looks at the various factors that go into knowing the social history of a patient. Obviously, this is pretty detailed. You are not going to be doing all of this in one go. But over a period of time, much of this you should be aware of. So I'll explain to you in the circumstances of a patient, recent patient of mine. She just passed away, motor neuron disease. She was 75 years old, recently widowed, living in Delhi. She was, as she said, very sound emotionally, in the sense she felt she was strong. Her perceptions of healthcare were such that she preferred to use homeopathy, but she was very clear about leading a healthy life. And in terms of access to and utilization of healthcare, she was doing that independently earlier. But at this point in time, she was going to be taken care of by her son, who was planning to be managing everything for her. So you check out all these factors and you build a profile of the patient. And remember, at the beginning of this journey, of course, Subhash told me palliative care bilkul mat bolna, but I can't help that because, well, whatever I am doing today, to a large extent, is because of my recent orientation towards palliative care. So remember that when you look at the beginning of a disease, you have the map, the patient does not. Never forget that. When you deliver the diagnosis, be aware of how you're delivering the diagnosis. For instance, you may think the diagnosis is no big deal. You're the first physician making this diagnosis, and you just drop a bomb on them. And Parkinsonism literally can be a bomb when patients are unaware that they are heading in for it. Or there may be genuine uncertainty about the diagnosis, but it is potentially a bad diagnosis, potentially treatable. So a young person with relapsing remitting MS, potentially bad, but as of now, completely treatable. So when you give the diagnosis, you need to judge when the follow-up will be to deal with the aftermath. It may be as soon as a week, it may be as long as 4 weeks. Typically, I ask for investigations and I call them back, but I'm calling them back to see how they are coping with the diagnosis. And if this is a diagnosis that you know that the patient will die with and that you find personally difficult, then remember, you're heading into a minefield and you need to know how to handle this. And the first challenge always is telling the truth. This is an old quote from politics, not from medicine. Falsehood and delusion are allowed in no case whatsoever, but as in the exercise of all virtues, there is an economy of the truth. It is a sort of temperance by which a man speaks truth with measure that he may speak it longer. And we are repeatedly told, Usko mat batao. So we really don't have much literature on this, except this paper that came out just recently, late last year from Tata Memorial Hospital, which applies to cancer, but it applies to all of us. And when they ask dyads, patient caregiver, greater than 80% of patients wanted to know the diagnosis and prognosis because they wanted to be prepared to plan additional treatment, anticipate complications, and plan for the future and family. Depending on the question that was asked the caregiver, 60 to 80% of caregivers would restrict information because it would negatively affect the future course of the illness, cause the patient stress, depression, whatever, all that. So please understand, Indians are humans. We are not very different. And these are figures that have been replicated all across the world. Now, how do you do this? It is a protocolized discussion. You need to be aware of the protocols that you can use. They are available, but more importantly, we need to be trained. Remember that this kind of communication is a procedure as much as a surgical procedure. It needs training, it needs assessment, it needs practice, and it needs reflection after that. Did I do it right? How should I do it again? What is the equivalent that I take? Look at driving, for instance. You are in a car. You're driving full speed in your lovely new sedan. Okay. Now your sedan has to go off the road and into mountainous terrain. That is not possible. So think, if you have communication skills, then you have acquired a off-roader with four-wheel drive. And when you hit this kind of difficult situation, you are completely prepared. You shift to first gear, you put the four-wheel drive on, and you're good to go. So this is something that you're not going to be using every time, but when you do need to use it, you have to have this. So how I do it, tackling family, etc., especially in motor neuron disease, towards the end of the first consultation, I give the correct name of the possible diagnosis. When they say, Usko mat batao, I tell them it is my job or responsibility to speak to her, not yours. You remember that it is only when the first neurologist does this, Usko mat batao, joins in that after a little while, the wider family gets involved and the Tauji and the Masiji all come in and say, Usko mat batao. When the diagnosis first appears, the immediate family is also shell-shocked. And when you say, this is my responsibility, they will say, take it. When you drop it, it gets worse and worse. Of course, you have to acknowledge diagnostic uncertainty, suggest a second opinion. More importantly, make a second appointment for discussing the diagnosis and its implications. Why do you do that in the Indian situation? Because we do have to respect the family. So towards the end of the first consultation, I specifically ask the patient, do you want to talk to me about this illness? Or would you prefer that I talk to XYZ? And you leave it to them to sort this out before the next appointment. At the next appointment, you discuss the meaning of the diagnosis. Preferably keep prognostic discussions for later, especially swallowing and breathing difficulties. You don't want to discuss them that. But when you tell, hello, Mansi. Hi. I think Subhash needs to be.
Yeah. Tell me, Roop.
नहीं, आवाज कुछ आ रहा है पीछे से. Yeah. Okay. So when you are talking about ALS, acknowledge that this is not a good disease, but discuss reasons for hope. Explain that the complications are treatable. Explain that you will make every effort to maintain the patient's function and that you will listen to the patient. Remember that the patient needs assurance that you will not abandon her. There are patient support groups available. There is neuroprotective treatment available, and take a second opinion. But the most important thing is to make it clear that you're not dumping the diagnosis on them and vanishing, because that is bad. And when you do this, you make a mental pivot. You make a mental pivot from cure to care. We are always trained in curative medicine, where we seek to return patients to their own lives so that they might independently pursue their own priorities and do so in the manner of their own choosing. Fine. So you fix somebody's fractionic fever and they go back to scuba diving or whatever. But you might have to change priorities by changing to care when you have to assist patients in leading their lives and supporting them in the pursuits that they wish to prioritize in the time that they have left. As neurologists, we work together, sometimes for decades. And when you do this, you're actually practicing palliative medicine. So the first challenge is maintaining occupations such as driving, etc., and so on. Remember that continuation in the job needs individual assessment. Ideally, you should have a medical social worker to help you. When you ask for certificates, be aware of standard requirements. If Indian versions are not available, check international websites. And again, I don't give these certificates as at the end of the consultation. Acha, humko ye certificate bhi deta. No, that needs a specific appointment. And I get very irritated when they just dump it on me at the end. Especially a signature thumb impression verification, I might confirm inability to sign or write, but I don't certify their signature or the thumb impression. What about notification? And here is actually the other picture that was supposed to come in. That picture was of my dad. He's passed away some years ago. And he came and moved in with me in 2010 when my mother died suddenly. And about 2 years before that, he had closed down his practice. He was a lawyer, so he systematically closed down his practice. I knew that he had cognitive problems, but it was only when he moved in with me that I realized that his MMSE was actually 18. So which means that when he was closing down his practice, he must have been definitely in dementia. And yet he could close down his practice systematically. I have not heard any complaints. And remember that the profession that is going to be maximally affected by this issue are us. And we have physicians around us who are affected, and we need to be aware of this. We need to be able to do something about it. The most important is, if you're the neurologist, if you see something, say something. You have to inform. The next question that comes up is assessing decision-making capacity. This is important when you are looking at decisions for future care. People might want to make it, or for the living will, or for the estate will. And here it's a two-stage evaluation. You assess the severity of cognitive impairment. And here I would suggest a formal neuropsychological assessment, because you need this documented. Typically, above MMSE 24, they can make whatever decisions they like. Between 24 and 16, you will need to, and I'll show this how it's done, you will actually need to certify that particular instrument that they sign out. Below 16, by the time basic activities of daily living are getting supported, it's usually a little difficult, but they can be specific decisions can be applied to, can be sorted out. And when you are assessing this, you must apply it to the decision that is required to be made. So you have to assess the patient's ability to understand, to appreciate, to reason, and to express or communicate. And again, I don't think I have enough time. But anybody who's interested, this whole material, I'm happy to send it across. So please, I'm going to be going a little fast. So please write me a mail if you're interested. Some time ago, I was told that by a senior colleague, that if a patient or a patient's family asks for certification of a will, I tell them to go elsewhere. No, I don't. I don't think it is part of our responsibility to do this. And if you read this paper, you realize that it roughly follows from what I told you in the previous slide. Okay, so now the patient is in a stage where they are becoming dependent, and you have to begin this odyssey with them. What about follow-up? I think a follow-up, you offer them the choice of follow-ups between 3 to 6 months. Annual follow-ups are for patients who are completely stable, like patients with epilepsy whose seizures are completely controlled and so on. Otherwise, it's a patient's choice between 3 and 6 months. Typically, towards the end, it becomes every 3 months. I usually set up an electronic contact mechanism, either WhatsApp or email. You have to be aware of major life events in that patient's life, retirement, death of spouse, and so on. And you have to turn and look at the person with the patient. And I'm going to use these 3 terms because I use them clearly, separately. The care partner is a person who accompanies the patient because the patient needs help with logistics, but the patient is still autonomous and takes her decisions herself. So typically a spouse. And then, as we see it, perhaps it's the spouse who's there, or maybe the spouse passes away, and the patient becomes more dependent, and then you have an adult child or a sibling or somebody else becoming the caregiver. And often you change over. I mean, the role changes over, and then you have a paid caretaker. So please remember, at least I use these 3 labels separately. So they refer to increasing levels of dependence. If it's a relative, I do not like my resident saying relative of so-and-so. No, this is Jyoti. She is the eldest daughter of Mr. Joshi. And I think it's important for us to note this down in our files because frankly, we forget. The level of commitment of that caregiver varies depending on the dependence. And sometimes you will see extraordinary commitment, especially say, for instance, in a young couple where one person has been affected by, say, a severe brain injury, left in a persistent vegetative state. And it's the other person who literally holds off death and pulls them along, refuses to let go, and so on. And you have to respect that. Now, ideally, when you are doing all of this, you require a multidisciplinary team. This is an example of an MDT for MND. And you will see at the top of the list is a neurologist, at the bottom is a palliative care physician, and there is other roles in between. But actually, it's a circle between the neurologist and the palliative care physician, if you have that available. And all the rest also are encompassed. Basically, you need a holistic approach to maintain functional independence as long as possible with psychosocial support for patient and family. Another big issue that comes up is mobility and assessment of fall risk. If anybody is interested, the TINETI performance-oriented mobility assessment takes time. It's usually done by physiotherapists, but what you can do is the basics of the get up and go test. So basically, you ask the patient to sit up in a straight chair. It shouldn't be low. It should be reasonably high, the kind of chair that I'm sitting up. They get up without using the armrest, walk forward 3 meters, turn around, walk back to the chair, and turn and be seated. And you see sitting balance, standing, pace and stability of walking, turn without staggering. It has actually been timed. So at the age of 60 years, I should be able to do it in 8 seconds. By the age of 80, if I do it in 11 seconds, I'll be good. So if anybody is interested, there is this lovely review article on determining risk of falls and so on. It's free on the net. And when you look at this, you need to screen routinely. Anybody who's had 2 or more falls in prior 12 months, this needs to be asked. Because very often, by the time they come to you, everything is over and they are perfectly fine. And they don't tell you about it. So you have to ask for this. Of course, if they have difficulty in walking, then you will remember to, or if they come in with a fall. But otherwise, as a routine, please ask. Things to do if they have had, if their fall risk is significant, is to minimize medications, provide physical therapy, treat even simple things like cataract, watch out for postural hypotension. Just a diastolic drop of 15 may be significant. Always supplement vitamin D. If they can afford it, typically I get a vitamin D level once every year. But otherwise, all my patients are on once a month, 60,000 units, single dose. Younger adults, more vulnerable adults, it's once a fortnight, but once a month is standard. Manage foot and footwear. Are they coming in a broken chappal? No. Ask them to start using kids. Those are the safest. And modify the home environment, provide education, information, and so on. I'm going to run through these slides because there are all kinds of details here. For instance, in MND, you need to look at exercise. Now, range of motion is obviously straightforward. There has been some controversy about weight training, but it is probably useful, and one of my patients is happily doing it. Aerobic exercise is always possible. When you look at mobility, you need to look at upper body function, especially can they use computers, lower body weaknesses. You have more options, and say something like the dropped head syndrome will need a collar. What about spasticity, cramps, fasciculations? There are drug treatments available, including anti-epileptics. One thing that we don't ask for is fatigue. And here you need to look at energy conservation. You need to see if they have sleep apnea. And then if at all, you might use drugs. Patients with drooling, it's something that bothers them and can really affect function. Anticholinergics, of course, are possible. A simple option is atropine eye drops. But Botox is often used, and the last resort is radiotherapy. For pseudobulbar affect, the best drug is Nudexta, that's dextromethorphan with quinidine, not available in India, but you can have it imported. What about communication? As the patient becomes more and more dysarthric, whether it is motor neuron disease or PSP or Parkinsonia, one simple thing that I find is I ask the patient and family to write down their questions before the consultation. But you have a whole range of augmentative and alternative communication devices, and more are coming on the market. And if you have a support group, or if you have a clued-in caregiver, you can actually identify these. So the next big issue is pain. In ALS, it is related to immobility, so pressure relief helps. But otherwise, even simple paracetamol, up to 6, say about 3, maybe 6 tablets a day. Though normally, of course, I would not go beyond 2 grams, but up to that, towards the end, you could probably use. What about Parkinson's disease? There are so many causes of pain in Parkinson's disease, and I don't think we identify them or we look at them very carefully. So again, this is something that is free on the net, and you'll be able to look at it. From the palliative perspective, when you're treating pain management, you use the WHO analgesic ladder, where you go from non-opioids to weak opioids to strong opioids. And I would suggest that at least up to step 2, we should be comfortable and be able to use them. But there is another concept that comes in from palliative care, and that is a concept of total pain. People will complain of physical pain when their pain is not physical. It's actually psychological. It may even be spiritual. Ye mujhe kyun ho raha hai? It may be social, it may be isolation, and they will put it all together and complain of pain. And unless you look at the patient holistically, you may be treating pain and not been getting relief. The next is pressure injury. I'm not going to tell you the stages of pressure injury and how it occurs, except to point out that there is something called the Braden scale for predicting pressure risk. And I suggest this is one more of those documents that should be available in your, either in your nursing stations or in your inpatient notes. And I think we should also be, as consultants, also be looking at these. It's not just the nurse's job to look after this. Remember that if you score them, then you can actually see which are the patients who have a high risk of getting pressure ulcers. So obviously you correct the major risk factors like pressure, immobility, incontinence especially, and nutritional deficiency, especially say hypoalbuminemia. Remember that a pressure-reducing mattress is not a substitute for an appropriate turning regime. What about genitourinary symptoms? Overactive bladder. I'm not going to run through the drugs that are available, partly also because I have a very good neurourologist at our hospital, so that's all outsourced. But watch out for urinary retention and overflow. I'm not sure if any of you are aware of the cystocerebral syndrome. I've had this patient, a patient like this, a patient with dementia, which had been previously diagnosed, came in and with sudden deterioration. And after 3 days in the ward, for some reason, we got a USG, and suddenly we get a call from the USG saying that he has 2 liters of urine in his bladder. And as we put in the catheter, by the next day, his MMSE shot up by about 6 or 8 points. So when you are discharging an older patient, if you are part of the treating team, and if somebody removes the catheter and says, okay, he's passed urine, let him go, do not discharge the patient without a post-void residue check. And this is something that you should have a fairly low threshold for doing, a post-void residue by USG. The purple bag syndrome is when constipation and an indwelling catheter run together and products, so it can be quite dramatic. Constipation. Again, it's often mismanaged. We ignore psychological factors. We use laxatives suboptimally, and we forget that it can produce all kinds of other things. The Bristol stool chart is something that you should be aware of. And my friend, Dr. Janice Miyazaki, who's a movement disorders specialist, who's specialized, who's also now moved to neuropalliative care, says she keeps this chart on her table to show it to the patient. Well, you need to anticipate, you need to appropriately use laxatives. And if the patient is not passing, then the patient does need a rectal examination. Now remember, in PD, you have a whole bunch of non-motor symptoms. I'm not going to run through the list of these, except to point out that they are too many for any of us to remember. So how do you handle? What is the approach to look after patients who have these problems? One approach comes from palliative care, where they have checklists. And this checklist has been modified for Parkinson's disease, called the Edmonton Symptom Assessment System. This comes from Dr. Miyazaki's unit. But what I suggest is that we need to develop checklist assets. Why is a checklist important? If you want, you can read this up. This is a short version of, and then you can download Atul Gawande's book if you want. And I suggest that we need to collaborate and develop checklists for our setting and for our patients for refractory epilepsy, Parkinsonism, dementia. And the checklist should combine medical and non-medical issues. So for instance, all kinds of stuff. Have you asked about when he retired? Is he retiring? Last time it was his wife who had come. Why is she not there? As I told you, the wife may have passed away and you don't know. So this checklist will include both social, psychological, as well as medical issues, so that we keep track of everything that is happening in the patient's life. And when you have to deal with symptoms, remember, this is the EMA approach. This also comes from palliative medicine. Each troublesome symptom needs evaluation. It needs explanation to the patient and family. It needs management. It needs monitoring with attention to detail. You will do this if you know what you're doing. So, okay, moving on. The patient is deteriorating and you are now reaching a stage of a late stage. Now, as you reach this stage, you need to be aware of the disease that you're treating and its stages. For instance, I don't need to tell you about the Hoehn-Yahr staging system for Parkinson's disease, but are you aware when the patient has transited from 2.5 to 3 or going from 3 to 4? For instance, is this a younger patient? Have you discussed DBS? And then when patients ask you, have you thought about their life expectancy? They don't often ask you, but this is something that we should be aware of, that it has been stated that patients with PD die with it and not from it, which is not really true. Survival is definitely reduced in Parkinson's disease at almost all ages of onset. And over 70% Parkinson's patients die due to complications directly related to the disease, sepsis, respiratory failure, wasting syndrome, and so on. Once somebody reaches stage 5, survival is 2 years. Predictors of mortality, BMI less than 18.5 with accelerated weight loss. Reduction of dopaminergic medications because of neuropsychiatric issues, dysphagia, and so on. What about dementia? Please understand the fast scale for dementia. Very often, the family doesn't realize that a patient has reached fast stage 7, where ability to speak is almost lost, and almost at the end is the loss of the ability to smile, to hold the head up independently, which is when feeding also goes. And patients can still be walking at that time. So you need to be prepared for what is called serious illness communication. And there are various triggers for that. General triggers are age over 80 years and hospitalized, or when the patient or family wants to discuss it. But there is what is called as a surprise question. Would you be surprised if this patient died in the next year? And if you say, no, I would not be surprised, this is when you need to talk about it. For ALS, obviously, there'll be event-driven markers. Remember that foreseeing and foretelling were part of our responsibility till about the 1950s. And as medicine advanced, therapeutics became better and better. Prognosis dwindled from our knowledge base. And now we actually don't do it. Partly it's also because patients are more empowered and they expect us to prognosticate honestly, accurately, and optimistically. And frankly, if you're not trained in communication skills, you will not know how to do it. So we replace it with magical thinking and the ritualization of optimism. Maji, sab theek ho jayega. हाँ हाँ आप 100 साल की उम्र तक जियोगे. That is what one should not be doing. So when you want to do take the patient further and the patient wants to be, then you need something called advanced care planning. These are slides that I had prepared for the EPEC Neurology. It's a course that's being run out of Chicago, and you will get access to them sooner or later. But remember that even for American neurologists, this is not an easy job, because I am, in a sense, an advocate on a wider scale for advanced care planning, where I do bring this up. What matters is clarification of values and communication. And then, of course, documentation. But communication between you and the patient and the family, and understanding what matters to them. What are their attitudes to life-sustaining treatment? These are things that have to be discussed. If it is done well, then these patients do not use hospitals towards the end, and they often end up passing off at home, and people are happy. When should you discuss this? When patients are deteriorating rapidly. Sorry, these slides are a little bit. And as I said, these were made for American neurologists, so you can understand that even for them, these are not familiar things. So then you shift to the terminal phase. And here, preference-sensitive decisions, because some families, some patients will have different preferences. You must accurately elicit them. Make these decisions together. Be aware of your own cognitive biases. And then you go on to the decision-making that is really crucial towards the end. What about deciding about a PEG? You consider a gastrostomy if somebody has dysphagia and weight loss exceeding 10%, but also if respiratory function is worsening. Remember that there is this dichotomy between motor function and cognitive function. The worse the cognitive function, the less likely it is that a feeding tube will be useful. Whereas the better the motor function, the more likely it is that quality of life and respiratory compromise will be delayed with a PEG. So for people with severe dementia, fast stage 7, towards the end, where they are not able to speak, when they begin to swallow, they are then in the last few months of life. And sometimes they can go on longer, but we generally suggest hand feeding only. And these are algorithms for managing MND patients in terms of nutrition and respiration, and you have to take these together. So once you make a diagnosis of ALS, clinic visits every 3 months, continuing weight loss, discuss PEG, but do FVC. If the FVC has dropped to below 50%, this is a patient, and especially if it is below 30%, this is a patient who during the PEG can get intubated and end up with a tracheostomy which they may not want. So you simultaneously need to consider NIV. You need to talk to them about it. And if counseled well, most patients do not want invasive tracheostomy and invasive ventilation. But that is a decision that the family and the patient needs to take. It should not be a default decision that is made in the ICU. If the patient has to be managed for terminal respiratory failure, we are not used to handling morphine, and I require palliative care physicians to come in and help, but that can be done. Somewhere along the route, patients may talk to you about physician-assisted dying. That is not acceptable or possible or legal in India, and my own feeling is that we are at least about 20 years away from it. But MND is one of the commonest causes in those areas where it is possible for patients asking for physician-assisted dying. And then when families ask you how much longer, so one is the surprise question. And if intuitively, and this is an intuitive, if you're experienced, it comes in literally, would I be surprised? And if you say, no, I would not be surprised, you're likely to be correct almost 70 to 80%. These are intuitive answers. General indicators of decline, say for instance, somebody who was walking around the house is now bed or chair bound, requires complete help in self-care. All of these are markers. But given that these are little unpredictable, there's an error rate of 30%, which is to some extent linked to clinical experience. But you can do this, and there is this score which actually puts together numbers. So for instance, a patient with dementia who needs assistance with all ADLs and also have congestive heart failure, a total of 7 points. 1 year mortality is over 60%, which means that patient is definitely not going to be around 90% in the next 3 years. So at the end, these decisions cannot be taken by logic or by algorithms. And then we are looking for, we call them heuristic decisions. Heuristic decisions are decisions that to some extent are taken on the fly depending on preferences and so on. So whether it is treatment of pneumonia and life-threatening infections, how much treatment of pain to give, how much treatment of agitation. If somebody is extremely agitated, would you sedate them to the point that they might aspirate? And so on. But as I said, to do all of this, you require to learn communication skills. And this is for my younger colleagues, because you know who my senior colleagues are in this picture. So we also need to learn how to manage the end of life. We are usually, at least I am not usually involved in managing them. But towards the end, your diagnostic accuracy increases to the point that you can say when somebody has less than about a month or two to survive. And this happens months to weeks before death. Episodes of confusion, increasing drowsiness, decreased oral intake start off in about 1 to 2 weeks. And then chain strokes, respiration, the death rattle, all of that are days to hours before death. But our job is not over once the patient has passed on. There are some things that you still need to, I have not added a slide on this. Typically, somewhere around about this time or a little around here, I explain to the family that it is time, if they have not done so yet, I explain to them that they need to have a general practitioner on board. This is because I cannot give a death certificate. And we've realized this, that in these COVID times, that's become a huge problem, getting death certificates. So please warn them about it. Because at the end, they will go through a huge amount of trauma if death occurs at home or so on. And then bereavement, well, bereavement is another topic by itself. Earlier, I would not get in touch with a family after somebody had passed on, but now it's become routine. I get WhatsApp messages from them that so-and-so has passed on. 3 days ago, I was invited to a Zoom condolence meeting. And I reply to that. If I think there's a little bit of issue there, then I make it a point to call up the family, hear them out. because these are things that people don't forget. To do all of this, you also have to be prepared to take care of yourself. And now this is a separate topic. If Sudhir is listening, this is one more topic for a Sunday. I'll leave you with this quote. The best test of a physician's suitability for the specialized practice of neurology is not his ability to memorize improbable syndromes, but whether he can continue to support a case of motor neuron disease and keep the patient, his relatives, and himself, this is of course in the days when all physicians were male, in a reasonably cheerful frame of mind. I'm going to close with this. And if anybody is interested, my email ID is here. If you want this presentation, I'm very happy to share it. Thank you so much. I have shot over time. Sorry, Subhash.
Roop, thank you very much. I think that was brilliant. In fact, there's a Hindi song, "Haan tum bilkul waisi ho jaisa maine socha tha." So this is how I had conceptualized.
Thank you so much.
And you know why we had thought of this chronically ill patients is because they are chronically ill. Their disease doesn't get well. And I think at that stage, whether it is MND or multi-infarct dementia or chronic head injury, they all have common issues. And I know many times that even
you
if
are,
you tell them,
you are becoming a palliative care physician.
even if, yeah, because of you, and thanks to you, because I have seen the change in myself. Previously when I used to see those wheelchairs in the OPD, and from the distance I would see, oh, he's that same chronic patient and he'll waste my time. Now it doesn't happen. Now I think it is part of my job to counsel him, to talk to him. And I have seen more and more senior physicians doing the same thing. And Roop, the credit must go to you that you have taught us that we have to handhold these patients, guide them, even if they have a general physician. It doesn't matter. Even the general physician wants our opinion, our consultation. And I think most of us are doing that. Thank you very much, Roop. And I think you have addressed most of the questions. I'm sure there are many questions, and I think you are available. You have given them your email and your mobile number, and maybe we'll have future series on that. So thank you very much, Roop. Now we move to the next session. The next session is, thanks, Roop, once again. The next session is a final talk by Dr. Radhika Dhameja. She has already given us brilliant talks on neurogenetics in the previous programs. And today she is going to talk on a very interesting and important subject of gene therapy. Gene therapy, the cost, the ethics, and the other issues involved with it. So as you know, Dr. Radhika Dhameja is affiliated to Mayo Clinic. And may I welcome Radhika to give her lecture today, the final lecture on genetics.
So this is something like palliative approach to genetics in medicine. Huh?
Okay. Okay.
Well, maybe not quite, but we'll see. I have a few things I would like to cover, including gene therapy, some ethics and costs. So let's go along. So this is one of the slides I've shown previously, and I guess it kind of gives you a sense of how far we have come along from when we first were able to see the chromosomes under a microscope and were able to do karyotype, to now when we can actually sequence the entire genome. I'm trying to just move this here. So genetics has become, or genomics, I should say, hot topic, or at least before COVID. COVID is the hot topic right now, but before that, I guess at some point it was the hot topic in popular media, and it made it to many Time magazine articles, and I'll kind of highlight a few that you might have heard about. But coming to the cost, so I would have to say that it's a myth that genetic testing is very expensive. In the big scheme of things that patients undergo before they finally get a diagnosis, genetic testing is actually not expensive at all. So just to give you a sense of the cost has come along. When we sequenced the first human genome back in 2003, the cost was around $100 million. That's just so much money. And the Moore's law would have predicted that it would have followed this curve, but the cost has come down so much that you can get a whole exome sequenced for as much as you'll buy a new iPhone for. So just to give you a comparison, it's really not that expensive in the big scheme of things. And this is just not this graph telling you, people have actually looked at this systematically. So this study was published. It looked at comparison of the cost effectiveness of clinical whole exome sequencing with the use of, and it does support early use and reimbursement. So certainly this is going to be specific to United States because we can track the cost, as everything is really insurance paid and has fixed costs. And so there were 40 children, infants, who were suspected to have a genetic disorder based on their multiple abnormalities they were born with. And there were three models that this study kind of looked at. They said if they followed the first line, you do the basic investigations, you don't get an answer, you do more complex, then you do single gene after single gene, and you finally do whole exome. They were able to diagnose 12 of these patients. And if you look at the comparison, and the patients where they actually went straight to whole exome sequencing, the cost was much lower. And so they make an argument that you should actually offer whole exome sequencing early in the care of especially complicated children with a lot of congenital anomalies. In the right situation, whole exome sequencing is more cost effective. There's another study that looked at, again, whole genome sequencing and cost of hospitalization. So let's kind of walk through this graph together. They overall, when they started with 150 patients, but only about 48 were eligible. And the eligible criteria was that the patients had to be inpatient because they were trying to see how much inpatient cost these children took due to prolonged hospitalizations and surgeries. And they had to be infants under 1 year of age. The suspicion was that they're genetic, but they did not have a diagnosis. And finally, family consented in 42 of them. And if you walk through this graph, only 4 or 10% were able to get a genetic diagnosis by standard care, and 43% were able to get a genetic diagnosis by whole genome sequencing, out of which 31% changes in management were made. And in several, there were changes in healthcare models that were used. And there are many examples they kind of give here. So for example, this first patient, the diagnosis using genomic sequencing was made only at day 7, and NPC is Niemann-Pick C1. So the diagnosis was able to be made on day 7 of this patient's hospitalization, and the cost avoided was about $27,000. Similarly, they give many examples. Another more pertinent to our neurology is KCNQ2. So it's a channelopathy that causes seizure disorder. So in a patient where next generation sequencing was done early, you were able to get a diagnosis on day 4, while if you had a patient where you did standard protocol and did not offer whole exome sequencing, so this was a control patient, you made the diagnosis at day 42. So you would have done Curative or CMA before you did panel and got an answer. So that here the cost avoided could have been, 180. So just a very large amount. Another patient they have here is NEB1. So NEB1 is a congenital myopathy gene. So again, you were able to avoid an EMG, a muscle biopsy, and general anesthesia, which would add up to a extremely expensive total stay for the patient. And so they compare the cost. So again, there are many other examples, but just to give a sense that in the right situation, ordering genomic sequencing early enough can give you a diagnosis where patients can choose, or even providers can choose the right treatment. Because you were on a palliative care topic, I guess they do have a comparison of a patient where, based on the genetic diagnosis, family opted for palliative care and there was significant cost avoided. So some of the ethical considerations that we all kind of try to follow as physicians in day-to-day practice, but maybe becomes a little more relevant when we're talking about genetic disorders, is obviously do good and do no harm. Gain as much information as we can to optimize treatment decisions. And this may be more specific here. I'm not very familiar with insurability in India, but in this country, sometimes based on genetic diagnosis, some patients may not be able to get certain benefits. especially long-term and long-term care. So like care in a nursing home when they're old, based on their genetic diagnosis. There is a law called GINA, Genetic Information Non-Discrimination Act in this country that does protect them, but only for employment and health insurance. It doesn't really protect them from long-term or disability. So this really has to be discussed with the patient, especially become important for discussions. For example, if you have a young patient with ALS and it's genetically driven, would that really change? Would they want to do genetic testing? And even for that matter, dementia counseling. So we always have to tell the patient what they're going to be getting into when they do genetic testing, and this just cannot be just ordered like any other blood draw. And then sometimes genetic testing isn't covered in terms of by their health insurance, and so I will show you some examples where actually genetic testing helped confirm a new diagnosis and change treatment for a patient, and eventually the insurance would pay for that testing. These two articles, I think when I emailed before I started the talk, I did send these both. I would recommend, if you are interested in just going over everything I talked in a bit more detail, I would refer you to this genetic diagnostic for neurologists, and then whole exome sequencing. There are many, but this is more specific to child neurology. So I'm going to kind of walk over this one. So this study is only specific to children with neurologic disorders who underwent whole exome sequencing. So they had 78 patients from a child neurology clinic with a variety of neurodevelopmental disorders with no diagnosis. So they could be developmental delay, intellectual disability, cerebral palsy, or autism spectrum. The mean age at which whole exome sequencing was done in these individuals was about 8 years. And there were some who were from a consanguineous union, though obviously the diagnosis wasn't known. So the diagnostic rate in this study was a bit higher than what I had been mentioning before. So typically we say between 25 to 35% or 35 to 40, but this is close to, I guess, what usually is, but it's not surprising because all of these patients were from a neurology clinic. And so we're not surprised to see the higher rate. And they were all young children. So again, they were able to diagnose intellectual disability, developmental delay, genetically driven in 28 patients. Now, how did this whole exome sequencing help? Diagnosis is one thing, but I think the most important point from this paper was that this helped provide information to family members for their reproductive planning for future children. Now, you make a diagnosis very early for these children. You can certainly tell them how they could have healthy children in the future. Certainly, these are devastating neurologic disorders. A couple of days ago, I saw a 2-year-old who has infantile metachromatic leukodystrophy, and her mom was like, I was already planning to get my tube ties. I can't have another child with this. And we were like, no, we can help you have a child who can be healthy. And this is what I'm getting at. So genetic diagnosis, if you know what you're dealing with, you can certainly offer pre-implantation genetic diagnosis. And you may be familiar with this, but essentially in vitro fertilization with an extra step added where you check for the gene mutation and essentially implant the embryo that doesn't have a mutation back, so that families are given the option of having healthy biological children if you're able to figure the genetic diagnosis out. Now, I also wanted to bring this adult patient where genetic diagnosis did help change the management. So this was a very interesting case. She was a 57-year-old female who came in with a 20-year history of what she said she was diagnosed with is primary progressive MS. So she had been in a different part of the country, and she moved to Arizona, and she came to her MS clinic just to establish care. She said, I already have a diagnosis for primary progressive MS. She had actually been on some of the initial trials for the first drug for primary progressive MS, and she had done a lot of patient drives for raising awareness for MS, but something just didn't feel right. So our MS colleagues, very smart, they said, well, I don't think she has primary progressive MS. I think she has something different. And they repeated her imaging. So her spinal cord MRI, it's very faint, but she does have these linear T2 hyperintensities all along her posterior cord. And then she said something very specific about her ankle. She said, my ankles always have these fat deposits. Well, she didn't say fat, but she said they always have these deposits and I've had surgeries and I don't know what's going on. And my sister also has these. Anyway, so this was a clue that she has a metabolic disorder. This is called cerebrotendinous xanthomatosis. You know, the classic presentation of this disorder is one of where you get deposits, not sure why, but always at the ankles. And so we did check her cholesterol level, sequence her gene, and you know she has a very, very rare form of CTX where it only presents with progressive spasticity. And so she was taken off her primary progressive MS medications for which she's been spending thousands and thousands of dollars and was put on a very inexpensive, cheap chenodeoxycholic acid, which is treatment for this disorder. Anyway, so those are two examples of how genetic testing can certainly help certain patients. Now coming to patient autonomy and discussion of what are they getting into when they're getting whole exome sequencing. So remember, when you're doing whole exome sequencing for a patient, you may actually be able to find sometimes incidental findings. And what do incidental findings mean? Just as when you do an MRI brain of a patient, of a headache patient, and you find white or T2 hyperintensities or flare changes that you just say, it's because you're unhealthy, you have diabetes, you have hypertension, that's why your brain looks that way, we don't know what it is. Similarly, when we do whole exome sequencing, we may find variants in many other genes, but in some cases in very important genes where it actually may give them a diagnosis and they would have to change something about their management. So this is what I mean by incidental findings or secondary findings in whole exome sequencing. So I'll tell you why there's a heart over there. So there's a list of 59 disorders that ACMG, which is American College of Medical Genetics and Genomics, has put out, that a lab and I'm not sure if this is followed in India, but this has to be followed in our labs, that there's a list of 59 genes that if you find a pathogenic change or a mutation in these 59 disorders, you should report it, because these are life-altering diagnoses. So the first half of the slide on the left is all cancer diagnosis. So like BRCA genes, Lynch syndrome, or von Hippel-Lindau, neurofibromatosis, tuberous sclerosis. And you would expect that patient, you should probably already know if the patient has that, but not always. Sometimes they may not tell you about their cancer diagnosis or the family history of cancer. And sometimes as a neurologist, we may not ask those questions. So these are called incidental findings. And there are a bunch of cardiac genes, for example, Marfan syndrome genes or cardiomyopathy genes, or prolonged QT syndrome like Brugada syndrome genes, hypercholesterolemia genes, and then some carrier status for Wilson's disease, OTC, which is a urea cycle disorder, ornithine transcarbamylase, and then malignant hyperthermia susceptibility, which again, anesthesiologists would tell you that it would be nice information to know if they have that gene. So this is a list of 59 disorders that I have to show this list to the patient every time we get whole exome, that we will get information of this, but because at least in this country, patients have a lot of autonomy. They're the boss, not the physician. And so they have an option to opt out. Incidental findings happen in about 3 to 5% of all samples we send for whole exome sequencing. And so it's 3 to 5 in every 100 people will have some of these genes, which will have a pathogenic mutation, which is a big number, but patients have the right to say that I don't want to know anything other than what I'm seeing you for today. So if it is seizures, just tell me about that. I don't want to know if I have a cancer gene. But I would have to say from practice, most patients actually say, tell me everything. But they do have a right to opt out. Now, what about children? Recommendations for seeking and reporting incidental findings is not limited by age of the person being sequenced. So I guess in children, parents give consent. So if parents say, no, I don't want to know, then you have to listen to them, but the guidelines are not different. So that is regarding some ethical principles of why we do genetic testing and how much autonomy a patient has. Now coming to a very interesting topic of gene editing and gene therapy. It'll come to that. You might have all heard of this gentleman, Dr. He. He's a PhD scientist in China, And he came out in November, it was right after, before Christmas in 2018, with a YouTube video and said that he had made first gene edited babies in China. And nobody obviously had any clue of what he's saying, but he had essentially used a technology called CRISPR, which is a DNA editing technology. And I'm not a scientist or a PhD, so I won't be able to tell you anything more than that there's a technology out there that can edit genes. But essentially, he said he's made babies. So what he had done, so CRISPR has been there for a long time. That it's gene editing is available, but it is just the ethics around, you know, that can this be used in a clinical setting? So, you know, it became famous that everyone had been standing around looking at this weapon, which obviously they mean CRISPR, but this guy just came out and walked up and pulled the trigger before anybody was quite clear where the thing was aimed at. Because the problem with gene editing is that there can be many off targets. So what I mean by off targets is you're trying to target one gene. In this case, he had edited the CCR5, which is a receptor for HIV gene. So he made two twin babies who were born to an HIV positive dad and an HIV negative mom. And he just edited the gene out. So he said the babies cannot have HIV. So that was the whole point of doing gene editing for this, in this situation that he did. But the ethical concerns were, well, he tried to only take that one gene out. Could he have accidentally disrupted any other gene? But and I'm going to show you a very interesting YouTube video that he actually posted. He said he's done whole genome sequencing on these embryos many times before they were implanted, and there was no other off targets, which is hard to believe, but that's what he said. So if you actually search rogue scientist, you'll find him. It was a lot in the news right when it came out, and soon after this, the YouTube video, New England Journal, at least one of the issues right after, so January of 2019, about now a year ago, or more than a year ago. So he came up in November of 2018, and this was all 2019. It was full of gene editing, because people had wanted to do it for the longest time. And this guy just said, well, I just did it. So I think this is worth watching together. It's just maybe 4 or 5 minutes, but I think you'll all kind of enjoy it. So let's.
Two beautiful little Chinese girl in the.
Can you hear the video of the YouTube or the audio of the YouTube? Can somebody tell me? When
Yes.
I play?
Yes.
Okay, cool.
Came crying into the world as healthy as any other babies a few weeks ago. The girls are home now with their mom, Grace, and the dad, Mark. Grace started her pregnancy by regular IVF, with one difference. Right after we sent her husband's sperm into her egg, we're also sending a little bit of protein and instruction for a gene surgery. When Lulu and Lala was just a single cell, this surgery removed the doorway through which HIV entered to infect people. A few days later, before returning Lulu and Lala to Grace's womb, we checked how the gene surgery went by whole genome sequencing. The result indicated that the surgery worked safely as intended. Grace's pregnancy was normal, which we monitored closely by ultrasound and blood tests. After birth, we again deep sequencing Lulu and Lala's whole genome. This verified the gene surgery worked safely. No gene was changed except the one to prevent HIV infection. The girls are safe, healthy as any other babies. When Mark saw her daughter for the first time, he said that he never thought he could be a father. No, he's found a reason to live, a reason to work, a purpose. You see, Mark has HIV. Discrimination in many developing countries make the virus worse. Employer fire people like Mark, doctor deny medical care, and even falsely sterilize a woman. Mark and Grace couldn't bear to bring a child into that world of fear. Mark's words told me something I didn't fully appreciate. A gene surgery that could save a child from a lethal genetic disease like cystic fibrosis or from an life-threatening infection like HIV. It doesn't just give that little boy or girl an equal chance at a healthy life. We heal a whole family. As a father of two girls, I can't think of a gift more beautiful and wholesome for the society than giving another couple a chance to start a loving family. The media heaped panic about Louise Brown's birth as the first IVF baby. But for 40 years, recognition and morals has developed together with IVF, ensuring only therapeutic application to have more than 8 million children came into this world. Gene surgery is another IVF advancement, and it's only meant to help a small number of families.
So I'll stop there because he keeps going and gets into more of the same thing. But essentially, that's what he did. And he obviously is arguing for it. So just to clarify, gene editing is not available clinically anywhere, maybe except in China, but he is on a run and nobody knows where he's at. So, but I think just along the same principles, I think gene therapy is certainly FDA approved for many, many indications now. And you might all have heard about the SMA, Duchenne's muscular dystrophy, and ALD. I'm going to show you at least one example and then tell you where you can go to find all the gene therapies that are approved. But the principle is similar. I'm going to bypass that YouTube video. So there are two ways of doing gene therapy. One is ex vivo and one is in vivo. So in ex vivo gene therapy, you're taking the patient's blood cells and you're putting the gene in patient's blood cell and then putting them back into the patient. While in vivo, you're actually using a carrier virus with the gene attached to that virus or inside that virus, and then as a vector, and then you're injecting it to the patient. So mostly ex vivo gene therapy is for cancer, so leukemias, hematopoietic cancers, while in vivo is what you'll hear mostly in our neurologic diseases, wherever it is approved. So these are just pictures of how it happens. So you do leukapheresis or bone marrow harvest. You do the virus-mediated transfer of the therapeutic gene. And this, again, the ex vivo can be used for a variety of disorders. And the in vivo doesn't use the patient's cells, but actually just transfers the virus with the cell directly into, and then you finally reinfuse. So let's come to a genetic disorder where this has been studied. So X-linked adrenoleukodystrophy, I picked this because it is a neurologic disorder and it is genetic, certainly. And then it can have both pediatric and adult phenotypes. So it is the most common paroxysmal disorder. It's X-linked, so it affects males, about 1 in 15,000. And the biochemical abnormality in this disorder is the deficiency of a peroxisomal membrane transporter. So it is not able to transport the very long chain fatty acids across the peroxisomal membrane. So there's elevation of very long chain fatty acids, which really is what is behind the pathology of this disorder. So the form that is really severe and lethal is the childhood cerebral form, which happens about 30 to 35% of patients. But the most common form, which you as an adult neurologist may see in the clinic, is the adrenomyeloneuropathy, where essentially patients present with progressive spasticity, and that's really the phenotype. And then rarely they can have Addison's disease only phenotype. So the childhood cerebral form presents in young boys. They typically have normal development early on, and then they start with behavioral and executive function changes, mostly get a diagnosis of ADHD early on. And then this is followed by regression, progressive spasticity, vegetative state, and death within a few years. MRI changes precede neurologic manifestations always. And just as the name suggests, they do have adrenal insufficiency, and that's why it's called adrenoleukodystrophy. Now, there are many different MRI patterns in this disorder, but the most common form is where the white matter is affecting the parieto-occipital lobes and the splenium of the corpus callosum. And then there are some other rarer forms where you can have just the frontal white matter, a combination, cerebellar or corticospinal tracts, but these are very less common. And so this is really what we look for. And they often have gadolinium enhancement. So this diagnosis is actually part of newborn screen in our country. And once you have a positive newborn screen, they get put on an MRI schedule. So the first sign of MRI gadolinium enhancement, they are put on treatment. And the treatment is really stem cell transplant. That was the only treatment that is available for these boys. It can, but it has to be done really early when the changes on the MRI are rather mild. So this was the only treatment that was available for the longest time, is stem cell transplant. But the problem with this is, again, you have to keep them on monitoring, and it has to be done when the changes are really starting to begin and they're mild. But remember, half of these boys will never have symptoms. So again, you can't really give transplant to asymptomatic boys. And there's no way you can predict who will develop this or not. But stem cell gene therapy is now available for adrenoleukodystrophy. So that was stem cell transplant. That's different from gene therapy. And they use stem cell gene therapy is because they're putting into stem cells the gene. So this was again published in New England Journal. They had very small number of boys, obviously, because it's a rare disorder. And when there's already one established treatment for a disorder, to get them to do another one, it's always hard. But they had 17 boys in the treatment with a median follow-up about 30 months. And 88% or 15 of 17 of these boys are alive, or were alive at the time of the study, and free of major functional disability. And so this study proved that this was safe. And this was again an ex vivo lentivirus vector. Essentially, you take the gene, the name of the gene, the transporter is ABCD1, and you put it in a vector and you put it back to the patient. They obviously followed the viral copy numbers, the level of the ALD protein that was expressed after the gene therapy, and they were able to demonstrate a steady amount of protein. And the follow-up was at last follow-up, or at least in 3 patients, it was 36, but most of them were under 2 years. This slide just shows that most of them, so green or the lower end of the scale, is that they're doing good. They either have no change or they're alive. And then 2 patients died, and then 3 patients had some neurologic change, not in the right direction, but most of them stayed the way they were, and they were alive. So it's essentially gene therapy is safe and effective, and it's an alternative available to these patients to stem cell transplant with early stage adrenoleukodystrophy. So if you are interested in knowing what all diseases gene therapy is available for, so this is a link. It wasn't working, so I'm kind of just going to go there directly. If you go to FDA website and you go to gene therapy, you can find the list of all the disorders for which gene therapy is available. The latest in this list is, what is really amazing is the zolgensma. This has been approved for SMA. So SMA, as you may know, is like a motor neuron disease of babies. It's devastating. They don't live past infancy, I guess, depends on what form they have. But it is a really sad disease for any family to see a baby with it. But now with gene therapy, all they really need is one-time injection of this gene therapy, and the babies who did get this lived with no neurologic regression, and it has been FDA approved. So I'm going to show you a video of an SMA as well. Hopefully this will work.
Spinal muscular atrophy, or SMA, is an inherited disease that affects a child's ability to move muscles. A gene involved in the development of SMA is called SMN1. SMN1 produces survival motor neuron protein that helps motor neurons to develop connections between the brain and the muscles. Babies born with 2 mutated copies of SMN1 gene cannot develop proper brain-muscle connections. They lose their ability to move, talk, and eventually breathe. Zolgensma, a gene therapy developed by Avexis, is a therapy that fixes SMA at the genetic level. Zolgensma is an adeno-associated virus that carries a functional copy of SMN1 gene. Following intravenous administration, Zolgensma viral particles travel to the brain, cross blood-brain barrier, and infect the brain cells. DNA with SMN1 gene delivered by adeno-associated virus settles in cell nucleus and starts producing SMN protein. Babies treated with Zolgensma start gaining motor strength and reaching their developmental milestones. They get a chance to live healthy lives that we all take for granted. If you want to learn more about SMA gene,
So I think the gene therapy for SMA, when it was approved, I feel like that was a miracle in at least neurology in terms of treatment for genetic disorders. So briefly, not very relevant, but I wanted to just throw it out there, is the topic of healthy genome. So we have a clinic, thankfully I don't do that clinic, but we have a clinic that is really done for people like you and me who perhaps don't, or at least don't know that they have a genetic disorder, but they are curious to know if they are carriers of some genetic disorders. And so we call it healthy genome sequencing. It's actually commercially available in many places, but I just put 2 of the labs that offer Healthy Screen here. And essentially, this is not really whole exome, but it is, I would say, a very large panel of genes where if you found a mutation, you would perhaps do something different about your health. Say you had a gene for a cancer syndrome like BRCA or Lynch syndrome or neurofibromatosis. Many times patients may not know they have that. Or you have like a prolonged QT gene or a cardiomyopathy gene. And then carrier screening for a lot of recessive disorders, which may be actually relevant in certain populations where there's a lot of consanguinity. And so, there are a lot of labs out there that offer this direct-to-consumer testing. And there actually is a study that has compared the yield or reporting of direct-to-consumer testing, which essentially means that the patient is ordering and going to the website of the lab and just ordering for themselves. A physician or a genetic counselor is not involved, so direct to consumer. And it has led to a lot of inappropriate patient care, at least here. And so essentially the labs aren't reporting the right things. So they might be reporting, say, a variant of uncertain significance or a benign variant as a positive. So when they looked at this study, they actually found that the false positive rate was 40%. That is just bad. And if you break these 40% into what genes they were, if you look at it closely, many of them were actually BRCA genes, which is breast cancer gene, breast cancer and ovarian cancer gene. TP53 is also a cancer syndrome. CHEK2 is also a cancer syndrome. Collagen 3 is vascular Ehlers-Danlos syndrome, and these 2 are also cancer predisposing genes. So essentially, direct-to-consumer testing is not good to do, is the bottom line. So trying to summarize all the three kind of talks and overview and winding up with some ethics and gene editing and gene therapy is clinical genetics also does have a think tank. After careful review of records, family history, comprehensive phenotype, and then searching the appropriate database for a known syndrome, you can certainly follow a tiered approach. In no way advocating that whole exome or whole genome should be the first in every situation. But again, it does require a comprehensive review. So microarray or a metabolic workup followed by a targeted panel may be the approach in certain cases, but in certain cases, it might just be whole exome sequencing or whole genome sequencing. And in certain cases, you may have to tell the patient this doesn't smell like genetic at all, and you would not recommend any further evaluation. So the present of clinical genetic testing is collectively genetic or rare diseases are not rare. And genetic testing has evolved rapidly and certainly changing the way we are practicing medicine. And whole exome sequencing has improves diagnosis of clinically heterogeneous neurogenetic phenotypes. It does have a broad application. It leads to diagnosis in many cases where it can directly affect and improve patient management, like I gave you an example. And it does reduce its time to diagnosis in many cases, sparing extensive diagnostic odyssey and pairs with subsequent costs that may not be meaningful. And I guess that was my last slide.
Thank
so
you.
I will end there.
Thank you, Dr. Dhameja. I think that was very comprehensive, and you made it very clinically relevant for all of us. Thank you very much. Sudhir, you would like to say something? Sudhir is around? I don't know whether we have, Mansi, do we have any time? But actually, I don't see any
Yeah,
questions.
I can see him, but I cannot hear him.
Yeah.
We are at 12, so
Time is up.
we can, yeah, the time is technically up, but if you, maybe 10 minutes or so, if you want to extend, we can.
But I don't, do you see any questions? I don't see any questions.
There are questions, but I'm not quite sure whether they are related to genetics for Dr. Dhameja. Wait.
Yeah, yeah.
Somebody, I just answered one question. It said, does whole exome sequencing cover trinucleotide repeat? And I said no. Because I think I talked about in one of the talks earlier, it doesn't.
Yes, you did.
So I can't hear Dr. Kothari. I think he's trying to say something, but his mic is muted or it's not working.
Mansi, can you see what, is there any problem with the mic of Dr.
Yeah, my mic was muted. Sorry.
Yeah.
No. So I know that was one of the first things you told. If you have trinucleotide repeats, you got to, you have to diagnose it clinically. You can't just do whole genome sequencing because that will be missed. Okay, I think these have been a great series of.
So Sudhir, Sudhir, can I ask one question since we have 5 minutes?
Yes.
Sure.
Hello.
Yeah, we can hear you.
Yes, go ahead.
Yeah. No, Dr. Dhameja, see, many times when we diagnose any genetic disorder, in neurology, we usually see these hereditary sensory motor neuropathies or any genetic syndrome. Then we tell them, you go to genetic clinic for genetic counseling. So in genetic counseling, what do you expect a genetic counselor? Is it mainly about the future, about the reproductive aspect of it? What is actually a genetic counseling involve? What does a genetic counselor tell our patient, whom anyway we have talked to him, anyway we have made the diagnosis, and we grossly tell.
Before you answer, I'll tell one problem where I do feel that we have to send to a genetic counselor. Suppose somebody has Huntington's disease, and then his children, that guy asks, should I test or not? So it's a very difficult question. You got to talk to them. If somebody might be going to have 30 years of productive good life, but finding out today that I am positive for Huntington's, he might spoil his life. So it's not a very easy decision. You got to talk to them and find out, and maybe tell them that, okay, you can marry, but not have children. I don't know. What will you tell Huntington's?
Yeah. So, so I think it really depends on the disease. So CMT is pretty mild for most part. So I think a genetic counselor would probably only counsel about that it is dominant or recessive, depending on what type of CMT is and what are the risks for their children or siblings. Does anybody have symptoms? They may want to seek care. So I think CMT is rather straightforward, but disorders like Huntington disease or many FTDs or ALS, where the diagnosis is certainly very significant, especially if you're diagnosing it pre-symptomatically. So we have a protocol for Huntington disease families. If you diagnose somebody with Huntington's and if their siblings or children who are not yet symptomatic want to know if they have symptoms, they actually have to first see a psychiatrist, and they have to get kind of a clearance that they can take in a positive result, because they could end up being suicidal after knowing that they're positive. And many times, again, we discuss these issues. What are you going to do with this positive information? So they might say, well, I'm 30. This may want us not to have children, or may want us have children a different way, through in vitro or adopt or sperm donation, egg donation, whatever it may be. So I think patients have a lot of autonomy in this country, and they get to choose if they want to know pre-symptomatically, but they do have to see a psychiatrist and get in certain situations. So mostly our psych consults are for pre-symptomatic HD, frontotemporal dementia, where they could certainly become suicidal after. But CMT, I would say it's pretty straightforward. I'm not sure if I'll send my patient with CMT to a genetic counselor. You could probably do the same thing. Yeah.
So would you suggest that for each genetically, any genetic disorder, we should send to a genetic counselor who's probably better equipped to talk to them and
Yeah, I think if you have resources and the patients are open, I think you should, because sometimes we feel like we know everything about their field, but I think they do a better job in counseling, their counselors. So I would, but it certainly depends on patient motivation to also some extent.
And the other, sorry, I'm taking one little time, but we face this problem. Now we tell a person that you have got a 50% chance that 50% of your children will have the disease, 50% will not have. So what do you expect the patient to do at that time once you give him this information? You have got 50-50 chance, 50% of, how does that translate into real life, into real practice? What is your experience in this? What do the patients there say? Let us say there's an autosomal dominant disorder, and you tell him that now if you marry, you have 50% chances. How do the patients take it?
So I think, again, it depends on what the diagnosis is. So just to give you an example, I do the neurofibromatosis clinic where, the risk is 50%. It's very straightforward. But most of the younger people now, if they're females, they would say that, well, it could be either or, but they say that either they'll have biological children by egg or sperm donation. They'll not use the site that is affected, or they will do in vitro with pre-implantation genetic diagnosis. So I think it really depends on patient, and some families will say, well, it's God will, So I think it again depends, but I don't know if a Huntington disease family would say it's God will, So I think it again depends on the diagnosis, but you give them the options that we can send you for pre-implantation.
Thank you very much. My last question is that we have been looking with, you already touched it, but I would like to know from you again, that people have been looking at this CRISPR technology with a lot of enthusiasm, and they are thinking that it will change the whole scene of genetics, where we'll be able to do this gene surgery, which you showed in the YouTube. So what is your personal practical opinion on this CRISPR technology for future?
Yeah, so CRISPR is what they're using for gene editing. So that's how gene therapy is done, that you're using this. So essentially CRISPR is, you have the gene of interest, and you find targets along the gene of interest, and you cut the gene along those, you cut the gene along the targets, and either you put a new gene, which is what gene therapy is, or in gene editing like that Chinese scientists already did. So both of them are available. It's mostly the ethical dilemma that's holding us to use gene editing in widely. Otherwise, the technology is there. Somebody has made babies already, and perhaps he made many more after that. We just don't know. And you might have heard of mitochondrial or so patients with maternal mitochondrial disorders, where the egg has or the mitochondria of the egg has the mutation. In Europe, they had made a baby with one mom's nuclear DNA, another mom's mitochondrial DNA, and then the sperm with everything else. So like a 3-parent embryo. So I guess you could do anything. Technology is there. So gene therapy is certainly available. It's just very expensive, even with insurance here. It's tough to get it. But SMA, we're doing it in the clinic. They get one infusion and that's it. And it's almost like a miracle. The babies who would die in a few months are living healthy, normal life. So it's just amazing what gene therapy has done in certain disorders. Same with ALD, it's an option. These kids are obviously monitored. They go to certain centers to do it, and we have to send all the data to FDA and everything, but it's available in the clinic. So CRISPR is technology that is available. It's being used, but has to be used in the right setting.
Okay.
We're very far away, at least in this country, from gene-edited babies.
Okay.
But you can do it.
About SMN1, the disease often starts in the womb itself. So, is there any way that you might think of giving it before birth?
I'm sure somebody is thinking about it. It's probably just the delivery process, how mature the blood-brain barrier is. I'm not smart enough to answer that question, but I'm sure somebody is thinking about it. There are a few questions in the box. I'll just quickly
you can
answer.
them. Yeah.
Yeah. Is routine CMA for autism evaluation history or testing to be done, or only child to be tested? For CMA, you typically would start with the baby or the proband in front of you. You might have to do testing on mom and dad after the fact if you get a variant or you get a positive result, just to see where it came from and for counseling. But you can start with the baby. You don't need trio for a CMA to begin with. When we do send whole exome, will they look for microdeletions, or So if you send whole exome, I think our technology is getting pretty sophisticated that if there are deletions, they can pick it up, but that's not the standard way. So you will always order a chromosomal microarray before you would go to whole exome for microdeletions. So microarray has to be done. What is haplotype? And I don't know what that means. Anyway,
So
I think I
thank you.
answered. I'm not sure what the other questions really mean.
Thank you very much. I think that was very, very informative and very helpful. And I think that is the end of your genetics series, but I'm sure we'll again meet. We'll again organize something. Thanks once again.
Thank you.
So next week, as far as I know, in the office series, we are having 2 lectures. One is by me on transient neurological deficits, and one is by Meenakshi Sundaram on gait disorders. Sudhir, do you want to conclude and thank everyone?
Yeah, basically thank you and Roop for excellent talks. I must thank Radhika for a superb series of genetics, and we'll call you again. So I think
yeah, thank you. It was really fun doing this.
Thanks.
And we shall inform everybody. We have the students series on Tuesday as usual. So shall be sending out the link soon. Thank you.
Thank you.
Bye.
Thank you. Bye-bye.